A very good evening from all of us. On behalf of my team from Apollo Hospital, New Delhi, I want to thank ICA and Dr. Jayashree Sood, Madam, especially for giving us this opportunity. It's always a privilege and honor to be part of academic program of ICA on any given day. And with this, let's start our academic program for the day. With me is Dr. Anupam Raj, consultant, Apollo Hospital, and Dr. Chetan Mehra. I will be introducing them shortly. So share screen. So today I will be talking on anesthesia for CRS and HiPec, that is cytoreductive surgery and hyperthermic intraperitoneal chemotherapy. So HiPec is a technique in which hyperthermic intraperitoneal chemotherapy in a highly concentrated form is heated to a temperature of around 41 to 43 degree, and it is delivered directly to the abdomen during the surgery. So CRS basically stands for cytoreductive surgery, and it's a major debulking surgery. It can range from isolated omentectomy to a complete resection of multiple organs, and peritonectomy can be one part of it. So what was the rationale? Why did they combine CRS with HiPec? The rationale of combined approach was that peritoneal surface malignancies are macroscopic disease and microscopic disease. There are two components. So macroscopic disease is taken care of by the CRS or cytoreductive surgery, and the microscopic component is taken care of by HiPec. This results in improved outcome, and median survival at 5 years was seen to be improved. So what is the basic mechanism? So hyperthermia basically leads to selective destruction of malignant cells by inhibiting RNA synthesis, by increased lysosomal activity in malignant cells, by causing vascular stasis and inhibition of oxidative metabolism. So it all started in around 1979 when first patient was treated with hyperthermic thiotypa for pseudomyxoma peritonei. Then Dr. Sugar Baker developed the peritoneal cancer index in 1990, and completeness of cytoreductive score was described in late 2000. CRS with HiPec is a very complex procedure, and the outcome depends on the patient's pre-op health status, the disease load, the surgical factors, the intraoperative events, and the chemotherapy drugs used. What are the tumors that can be subjected to HiPec surgery? They are pseudomyxoma peritonei, peritoneal carcinomatosis from colorectal, appendicular, gastric, and ovarian tumors, peritoneal mesotheliomas, perforated GI tumors or invading adjacent organs, French tumors, etc. So appropriate selection of patient is important so that we have best outcomes. There should be a good performance status. There should be a favorable chemosensitive status. Age should be less than 70 years. And there should be any extension outside the abdomen. There should be absence of parenchymal liver metastasis or retroperitoneal nodes. The residual lesion should be less than 2.5 mm. The patient's hematological, hepatic coagulation profile and electrolyte profile should be normal, and there should not be any active cardiac disease. So Sugar Baker developed a peritoneal carcinomatosis index, and in which abdomen and pelvis are divided into 9 regions and intestines are divided into 4 regions. The PCI score is calculated by adding scores for each region to get the score from 1 to 39. If PCI is more than 20, HiPec is not offered. So surgical technique is mainly divided into 3 stages, wherein firstly an assessment is done either through an exploratory laparoscopy or through a midline full-length laparotomy incision. Once the assessment is done, a cytoreduction debulking surgery is done, wherein all the macroscopic tumor is removed, and then the abdominal cavity is perfused with a heated chemotherapy infusion. So just to give the perspective to those who are uninitiated to the HiPec, I am playing this animated video wherein I will tell you about the closed HiPec technique. So midline incision is given, and an assessment is done of the extent of the disease. All the macroscopic tumor, wherever it is in the abdominal cavity, is removed. So once the macroscopic disease is removed from the abdomen, temperature probes are inserted on both sides of the abdominal wall. The inlet pipes for chemotherapy are put into the pelvis, and the outlet pipe is put in upper abdomen. They both are connected to the reservoir. This machine consists of temperature monitoring, infusion pumps, and reservoir for chemotherapy. So the temperature probes, they give the internal temperature of the abdomen. And ideally, it should be between 41 to 43 degrees centigrade. The abdomen is stitched back and then starts the infusate. So it is started at 1 liter per minute. And once the infusate is there, the temperature is noted. It should be around 42 degrees centigrade. And then the chemotherapy agent is added and pumped into the abdomen. And with the help of the pump, it spreads all over in the abdominal cavity and causes tumor lysis for the microscopic residual tumor. And then it goes back to the reservoir. Simultaneous massage is given to the abdomen for a better spread. This process is done over 30 to 90 minutes. And once this process is complete, then the midline is again opened and the perfuse is drained out. So the commonly used techniques are open abdominal technique and the closed abdominal technique. So in the open abdominal technique, the advantage is there is a manual stirring of perfusion fluid, which leads to uniform distribution of cytotoxic solution. But this technique is per se compromised because the heat loss may be there and there may be suboptimal exposure. Also, there is this risk of spillage of chemotherapy. So the next technique is the closed technique, which is the safest technique. So in this, a laparotomy skin edges are sutured watertight. Abdominal wall is manually handled during the perfusion period to promote uniform heat distribution. Large volume of perfusate is generally needed and higher abdominal pressure is achieved. After the perfusion, the abdomen is reopened and the perfusate is evacuated. So what are the key anesthesia consideration? There should be a proper pre-op assessment and optimization and prehabilitation of the patient should be done. In the intraoperative period, after the induction, the CRS and the HiPec phase has its own challenges, and mostly the patient recovers for a long term in ICU. So pre-op optimization is done. Optimization of comorbidities, patient's weight, body, height, etc. is noted. Previous chemotherapy records are obtained. Nutritional status is optimized. A written high-risk consent is taken, and stoma counseling and marking is done. Standard monitors are applied. There is a need for invasive monitoring. Both the arterial line and CVP is monitored along with the temperature. So general anesthesia techniques are used. Endotracheal anesthesia is used. Thoracic epidural is inserted. Standard IV induction is done. Consider RSI in Hughes pseudomyxoma peritonei, and anesthesia is maintained by volatile anesthesia with opioids. So some of the key aspects are like fluid management. In CRS phase, the intraoperative fluid loss may be as high as 8 to 12 ml per kg. There may be significant blood loss during this process. And then because the abdomen is open, there will be huge evaporative losses. So there may be third spacing also. So combination of crystalloids, colloids, plasma, blood and albumin is used to maintain euvolemia. There is a debate between the restrictive versus liberal regimen, but the consensus is that we should maintain adequate systemic and regional perfusion. So hemodynamic management is very important. So maintenance of end organ perfusion should be there. This is the goal. Hypothermia causes peripheral vascular dilatation leading to tachycardia, and closed technique can cause rise in CVP. So key to monitoring is arterial line BP, continuous BP monitoring, CVP pressures, and urine output monitoring. SVVP may help guide fluid status, but is not routinely used. So the goal is to maintain the intraoperative urine output, which is very important. since the incidence of acute kidney failure after CRS and HiPec ranges from 21.3 to 48%. And this is seen more in cisplatin-based HiPec medications. So the target is to maintain 0.5 ml per kg per hour of urine output during CRS, in which 2 to 4 ml per kg per hour should be maintained during HiPec phase, and 1 to 2 ml per kg per hour should be maintained during the post-HiPec phase. Maintaining euvolemia in the perioperative period is the key to a successful outcome. Significant coagulopathy is observed mostly during CRS phase, as there may be huge amount of blood loss, and in HiPec phase due to hyperthermia, protein loss, or chemotherapy. So this should be routinely monitored through intra-op INR, PT, and APTT measurement, as well as point-of-care testing like TEG or ROTEM. A restrictive transfusion policy should be adopted. Temperature management is key here. Maintaining normothermia is an important goal, because during the CRS, there is a risk of hypothermia, and during HiPec, there is a risk of hyperthermia. So CRS phase involves extensive debulking and surgical resection, and this may lead to hypothermia. So the fluids are warmed, and the forced air warming blankets are used, and the room temperature is monitored, and it should be kept above 21 degrees centigrade. So we use blanket roll, wherein which we can manage hyper and hypothermia both. So in the CRS phase, the temperature is set at 38 degrees centigrade. But in the HiPec phase, the controlled hypothermia should be initiated before initiating HiPec. So we should decrease the room temperature to around 16 degree. We should change to cold IV fluids, which are kept at less than 6 degree. We should use cooling blankets and use cold head wraps. So cold IV fluid bags should be wrapped in cotton sheets, and they can be used in axilla and groin. The goal is to not allow the temperature to rise above 40.5 degrees centigrade. So this is a blanket roll set at 30 degree for the HiPec phase. So CRS HiPec require analgesia coverage from T4 downwards. So a well-functioning epidural reduces need for intra and post-op opioids, and the opioid sparing effects of epidural results in decreased bowel atony. So we should have some knowledge about the chemotherapy also, because herein the exposure of local tissues is to a highly concentrated chemotherapy agents. Mitomycin C and platinum-based drugs are commonly used. So heating the agent increases cellular permeability and increases the tumoricidal effects. Cardiotoxicity, myelotoxicity, and neurotoxicity are commonly seen. Using HiPec is very detrimental in operation theater, and if we are not careful about the safety, then it's a very hazardous thing. Use of chemotherapeutic agents carries potential risk of inducing carcinogenesis if inhaled or if they are absorbed. So air contamination is there, which can lead to pulmonary absorption, and we have to be extra careful when we are manipulating the perfusates. So closed technique provides highest level of protection, and appropriate PP should be used by all the OT staff. There should be adequate ventilation, smoke evacuators should be used, and the doors should be airtight closing type. Postoperative care, ICU or SDO is must, since 40 to 60% patients are extubated post-op in ICU. We should monitor post-op physiological changes because of fluid shifts, correction of any coagulopathy since it lasts for around 48 to 72 hours post-op. Stringent fluid status monitoring should be there, and some patients may require parenteral nutrition. A routine complication, as is common in any supramajor surgeries, abdominal surgeries are there, like bowel perforation, anastomotic leakages, fistula formation, venous thromboembolism, post-op paralytic ileus, and complications of chemotherapy such as leukopenia. So what are the challenges? An anesthetist who is conducting CRS and HiPec should be vigilant about fluid management and hemodynamic monitoring. The challenges for him include fluid shifts, temperature changes, increased abdominal pressures, and increased metabolic rate. He should be well versed with point of care testing for intra-op coagulopathy, and epidural should be definitely put, and we should know about the chemotherapeutic agents used and their safety profile, and the patient definitely recovers post-op in ICU. Thank you.
Well, either you can invite the second speaker or if there are multiple questions in your question box, we can answer the questions.
Sir, I feel we should go with the flow and then with the seminar. And
Okay,
then
okay. Thank you, Sharma ji. Okay, go ahead. That way.
So I invite Dr. Anupam Raj, who is the next speaker. She's a consultant working with us in Department of Anesthesia, Apollo Hospital, Delhi. And she will be speaking on the topic of third spacing and anesthesia services for third spacing procedures in endoscopy suites.
Thank you, Dr. Anil, for the kind introduction. I think you need to stop sharing your screen so that I can start.
Oh, thanks. Yeah.
Thank you.
So, as I told you, she is a consultant with us, and she will be talking about anesthesia for third space endoscopic procedures.
Good evening, everyone. Let's start with the topic that has been given to me. Over the next 10 minutes, we'll be discussing the scope of various third space procedures, various pathologies which are significant from the anesthesia perspective, and the anesthesia pre-op preparation, intra-op management, as well as the adverse events related to the third space procedures. Now, the third space endoscopy is the magnus opus in the field of therapeutic endoscopy, and it has led to a paradigm shift in how the various pathologies have been treated in the endoscopy suite. Now, traditionally, endoscopists were limited to the GI lumen, which was considered the first space. The peritoneal cavity was primarily the forte of the surgeons. Now, the potential therapeutic aspects of the third space, which is the submucosal space, has been discovered, and we are using this third space to do more and more surgeries and help patients. The capabilities of interventional gastroenterologists have been significantly increased over the past several decades. The concept of submucosal endoscopy with the mucosal flap safety valve has enabled endoscopists to securely use the submucosal space and the third space. Paroral myotomy was the original procedure that was performed utilizing the submucosal space in the patients with eclasia cardia, and it still remains one of the main and most often performed procedure. Subsequently, the similar technique was used to remove subepithelial tumors either from the esophagus or from the stomach. Now, the technique of all third space procedures remains same. Usually, a submucosal bleb is raised. Through that bleb, a mucosal incision is made and a tunnel is created. Once the tunnel is ready, either a myotomy will be performed or a tumor is resected based on the pathology. Submucosal endoscopy is largely very safe and with a few adverse events. And once we recognize the possibility of these adverse events, it's a very safe procedure. And more oftenly, now more and more centers have started performing these surgeries as a part of the daycare surgeries. This video is just to give you an overview of the technique that we just discussed. So basically, the endoscopist enters through the mouth, and based on the pathology, they make a mucosal incision 8 to 10 centimeters above the entry point, away from the area that is to be treated, and a tunnel is created. Once the tunnel is ready, a myotomy is performed, or if it's a tumor, then the tumor is removed, and then the mucosal incision, which has been created, is usually stapled using the clips. Various third space procedures, endoscopies are done for various diseases like eclasia cardia, subepithelial tumors, refractory gastroparesis, Zenkel's diverticulum, and esophageal strictures. Also, the adult Hirschsprung's disease. Now, I have this slide shows only two pathologies, mainly because they are of the importance to us as anesthesiologists. Ecclesia cardia and Zenkus diverticulum both have the main problem that they create is that there is stasis of the food in the food pipe, the area which is to be utilized. A similar thing happens in the Zenkus diverticulum. Food particles tend to get stuck in this area of the diverticulum. So these both pathologies, along with the refractory gastroparesis, provide are very high risk for anesthesiologists for the aspiration from aspiration perspective. In ecclesia cardia, the lower esophageal sphincter is tight, which produces an abnormal peristalsis of the upper part of esophagus, and that's the main pathology. And here in Zenkus diverticulum, the esophageal mucosa bulges out of the Keelian triangle and thus makes a food pouch where the food tends to keep getting lodged. And when the patient comes to the pre-op assessment, the proper preoperative checkup of these patients is mandatory. Most procedures can be performed in a fully equipped endoscopy suite. General anesthesia is the preferred mode of anesthesia for most of these patients. Written informed consent is usually taken. Fasting guidelines will vary depending upon the pathology which is being treated and the procedure which is being performed by the endoscopist. Associated comorbidities and their workup is required as usual, and aspiration prophylaxis is mandatory. One word about the aspiration prophylaxis is that, both in most of these cases where there is gastroparesis or, motility disorders or diverticulitis, oral medications may not work or actually increase the risk of aspiration. So it is preferred to use the IV form of medications. Standard ASA monitoring using non-invasive BP, pulse oximeter, ECG is used. Capnography and end-tidal CO2 is mandatory for these cases. Invasive arterial monitoring and the serial ABGs can be reserved for the patients with severe cardiopulmonary disease. It is not required as a routine part. Periodic clinical examination of abdomen, thorax, and neck is required, so it's important to keep these areas exposed. I cannot emphasize it more that the aspiration prevention of aspiration is very, very important. Many of these procedures, like a POEM or a E-POEM or a Z-POEM, which is done for Zenkus diverticulum, there might be a initial gastroduodenoscopy which is required for these patients. This gastroduodenoscopy is best performed without any anesthesia, and any particles, if at all, in the esophagus or the diverticula can be cleared before proceeding for the anesthesia. And then the RSI is the RSI is to be used. Cricoid pressure, especially in case of Zenkus diverticulum, could be problematic because usually the diverticuli might be present above the cricoid area, so that can actually increase the aspiration risk. So similarly, it's prudent to avoid the positive pressure ventilation with the face mask. Any IV induction agent of the choice can be used. There have been studies, especially related to the POEM procedure, paroral endoscopic myotomy, that the nasotracheal intubation is better as it it helps, avoiding of the sharing of the airway. So still in our center, we are usually using the orotracheal intubation, and it can be done very safely. Positioning and the protection of eyes is important. Any form of control ventilation pressure or volume can be used. Important to maintain a target normocapnia in these patients. And we need to watch continuously for any sudden rise in EtCO2 or peak airway pressures. 20% increase from the baseline, a sudden increase of 20% from the baseline. We need to consider percutaneous abdominal decompression. However, we will along in the this discussion, we will see that usually this is not required. And here is the positioning of the patient. Usually they are supine. Like I said, the abdomen, thorax, and neck areas need to be exposed so that we can easily identify the insufflation related issues. And for the prone positions are required. Now, physiological changes are very akin to the laparoscopic procedure. CO2 is the preferred gas because it is colorless, non-combustible, and can be absorbed by the lungs directly. So this is the preferred gas. for the procedure. The physiological changes also remain similar to those of the laparoscopic procedures in most of the cases. Now, coming to the adverse events that are related to the third space procedures and are of importance for us. Pre-procedural, the most important thing is the aspiration pneumonia that can happen, and we have discussed that, specific pathologies in which it is even more important. Intra-procedurals, most common problems that we as an anesthesiologist need to manage are the insufflation-related injuries. Mucosal injuries and bleeding is also known in this time period, and then the post procedure there can be bleeding or infection related issues. Now there are various risk factors that have been identified during the third space procedures, and we need to be vigilant if our patient falls into any of these categories. Now, coming to one of the most commonly related adverse events, which is insufflation-related events, subcutaneous emphysema is one of the most common ones. Then again, because there is a continuous insufflation of gas going on, the capnothorax or capnomediastinum or capnoperitoneum is very commonly seen in these patients. A study was done which looked for a post-procedural routine CT scan of these patients, and they identified that pneumomediastinum and pneumoperitoneum was present in almost 80 to 60% of the patients. However, only 6% cases required any specific intervention. So most of the gas is usually absorbed after a period of time without any intervention. To prevent these insufflation-related events, it's prudent to use the carbon dioxide rather than the air. General anesthesia and positive pressure ventilation has been identified as preventive for the IREs, and it is better for the endoscopist to use the low gas flows during the procedure. Now, if you have identified that there are insufflation-related events which are happening, first and foremost, gastric decompression needs to be done with temporary pausing of the procedure to allow the CO2 absorption and suck out any air which is present there. Subtle changes in the ventilatory settings may be required to increase the minute ventilation and augment the carbon dioxide washout. And if in case, despite all these measures, if the patient's pressures still remain high, above 38 centimeters of water, and the CO2 remains above 50, then the needle drainage may be required. For a capnoperitoneum, a needle drain can be put in the right mid-axillary line below the costal margin. And for a capnothorax or a subcutaneous emphysema, an ICT might be required. For a patient presenting with the subcutaneous emphysema, look for crepitus or insufflation-related problems, hypercarbia, acidosis, or changes in the lung compliance, or a persistent increase in the EtCO2 above 50. Now, gas-related injuries are more commonly seen in the pathologies of esophagus because there is absent serosa. And in case of cardia and stomach procedures, because of the presence of thick muscularis propria, usually the gas-related injuries are not seen. However, because of the complex anatomy of the cardia, the mucosal injuries are more common. Mucosal injuries are known to occur to happen in up to 4 to 5% of the cases, and there is very less that we as an anesthesiologist can do to prevent them. For the endoscopist, usually it's better to use the liberal submucosal injections to prevent any mucosal damage. And it is also prudent for them to cut closer to the muscle because most of the cases myotomy is anyway required. So that helps prevent any holes happening in the mucosal layer. And carefully inspect for mucosa, both of the gastric and esophagus at the end of the myotomy. Now, bleeding, procedural or delayed, a major bleeding requiring transfusion is very, very rare. Delayed bleedings are known to occur in up to 48 to 72 hours, but usually very, very uncommon. It can happen at any point of the procedure, like during the incision, tunneling, or at the time of myotomy or resection of the tumor. Apart from that, the other adverse events that can be seen with these procedures include the delayed mucosal barrier failure, esophageal leaks, mediastinitis, pneumonia, atelectasis, empyema. We have already discussed all the strategies that are there to prevent the adverse effects. From the anesthesiologist perspective, like I said earlier also, preventing the infection by use of prophylactic antibiotics and aspiration of the esophageal contents before starting the procedures will help prevent any infections. And insufflation-related injuries events can be prevented by use of preferably the carbon dioxide, and then temporary stoppage of the procedure and augmenting the CO2 washout and decompression as and when required. Many of these procedures are now routinely performed as the daycare procedure. However, there is a learning curve. So at our center, we do not perform it as a daycare yet. Patients are usually discharged on day 2. Considerable postoperative pain has been experienced by patients, so multimodal analgesia can be provided to them. Another important thing to take care of them in the postoperative period is to take care of the nausea and vomiting, because that can precipitate bleeding, the delayed bleeding or the mucosal tear or the esophageal perforation. And most patients that are at center, they undergo an esophagogram at day 1 and followed by they are started on the liquid diet. Thank you for your patient listening. Thank you.
So our next speaker is Dr. Chetan Mehra, and he will be presenting about the anesthesia challenges in the management of bilateral lung lavage for the patients with pulmonary alveolar proteinosis, a case series of 6 patients. So over to Dr. Chetan, please.
Well, good evening, everyone. At the outset, I would like to thank the organizers and Dr. Anil for letting me present this topic, which is a very dear to myself. My topic of today is anesthetic challenges in the management of sequential bilateral lung lavage for primary alveolar proteinosis, and this is a case series of 6 patients. This disease is relatively rare, around 2 to 4 millions per year. It involves intra-alveolar accumulation of amorphous lipoproteinaceous acellular material, and this is mainly because there is an impaired clearance of surfactant by macrophages. There are essentially 3 subtypes, most common being the adult idiopathic variety, which is autoimmune, the neonatal variety, and the secondary pulmonary alveolar proteinosis, which is due to the exposure of things like miners, farmers. Lung lavage is the gold standard for treatment of patients who have significant symptoms of hypoxemia. The rationale being the removal of pathological proteinaceous material and anti-granulocyte monocyte collagen factor autoantibodies. It is usually performed sequentially, where the more involved lung, the more affected lung is lavaged first, so that it provides better exchange for subsequent lavage of the opposite lung. Now, to put my case in perspective, I give you an example of an air conditioner filter. Here you see that all the holes are choked by the dust. When we use a water jet to clean the AC filter, all the pores get opened up and it allows a good exchange, good ventilation. And this is the essence of lung lavage and alveolar proteinosis. To further explain my topic, let me give you another example. The case one is whether your air conditioner is not cooling, right? You've tried everything possible, and after you're tired, you called a mechanic. He finds that the filter is choked. So in correlation to our topic, it means that the patients with pulmonary alveolar proteinosis have late presentation, and their diagnosis is also very challenging. Case number 2. Now you have cleaned your air conditioner filter, but you have installed the system in the same environment. and it gets jammed again because there is dust everywhere. So in correlation to our topic, it means that even though the patients who have been offered a lung lavage, in case they still work in the same environment, they will again have the symptoms of hypoxemia. Case number 3. Now you have bought a better air conditioner and you have installed it in a better environment, but still it will get blocked after some time. So in correlation to our topic, even though you give uh, immunomodulators in the form of GM-CSF factors, patients will still develop the symptoms of hypoxemia maybe later in their life. So with this background, I start my presentation where I'll discuss the investigations and diagnosis, the induction of anesthesia, the methods of lung isolation like fiber optic bronchoscope, the techniques of finding the seal pressure like capnometry, underwater seal, different phases of lung lavage like inflow phase, percussion physiotherapy in the drainage phase, and how do we diagnose lung soiling and how do we treat it, and post-procedure management in ICU. Now, almost all our patients presented with non-productive cough and progressive exertional dyspnea. If you see this table carefully, you will find that most of the patients belong to the younger age group. They were hypoxemic. They required ventilation of some form, maybe invasive or non-invasive, and most of them had occupational exposure. Now, this table shows cases of 4 patients. The 5th and the 6th patients were only housewives with no exposure, with no occupational exposure. When we investigated these patients, they are found to have bilateral asymmetrical infiltrates in chest X-rays. They have moderate restrictive pattern in PFTs. Their chest CT shows a crazy paving pattern, which is because of interlobar septal thickening. Bronchoalveolar lavage gives you pass positive and diastase resistant material, and the confirmation is done by using a transbronchial lung biopsy. Now you induce, after you explain the patient thing to the patient, you induce the patient in semi-sitting position with the tight-fitting mask, 100% oxygen, and you wait till the time saturation builds up to 95%. Then you induce the patient with titrated doses of propofol and fentanyl, and you secure the airway using appropriate size left-sided double lumen tube. Now, pre-oxygenation cannot be overemphasized, as it is mentioned that the retained nitrogen bubbles in the alveoli, they limit the effectiveness of lavage. So we induced the patient, we maintained the patient mostly with TIVA-based technique. We have used inhalational also, but we prefer TIVA. The reason being, there are numerous episodes of disconnection of double lumen tube for confirmation by using fiber bronchoscopy in case the soiling occurs on the opposite side. In that case, the depth of anesthesia can vary, and the patient can have awareness during the procedure. To take care of all this, we also use BIS monitoring. The pressure control ventilation strategy in line with one lung ventilation protocol and CLABGs was monitored. IV fluids were restricted only to antibiotics and infusions. Patient was positioned in lateral decubitus position. It's important to understand that the non-dependent lung was the one to be lavaged. Okay. The pressure point protection was carried out because it's a long procedure. Eye care, DVT prophylaxis, and antibiotics were given. We made sure that we had good access to both the DLT probes throughout the procedure, because these need to be handled in case you need to reconfirm the position of DLT. For confirmation of lung isolation, we used sequential clamping and unclamping by auscultation and fiber optic bronchoscopy to confirm the anatomical separation of both the lungs, absence of lung sliding sign, and presence of lung pulse by ultrasound, and use of capnometry underwater seal were used for functional separation. Now, to prepare the apparatus for performing the lung lavage, we modified a TORP set. This is a TORP set, one limb of which was the inflow limb. It was connected to the lavage fluid reservoir. This reservoir was placed 30 centimeters above the patient's chest wall. The other limb of the TORP set was a drainage limb, which emptied into the drainage fluid connector. The straight limb of the TORP set was then connected to the double lumen tube, one limb of which was inside the non-dependent or the lung to be lavaged. The other lumen of the double lumen tube was connected to the ventilator for ventilation. Now, the first phase of lung lavage is the inflow phase. In this phase, the fluid moves from the reservoir through the inflow limb into the through the DLT to the non-dependent lung, just to be lavaged. Fluid gets accumulated here. Then starts the second phase, which is the chest physiotherapy phase. This lasts for nearly 5 minutes. After this, the third phase starts, which is the drainage phase. In this phase, the fluid moves out of the double lumen tube from the drainage limb and into the drainage reservoir. Now, this is the setup in situ. Here you can see that the modified TURP set is connected to the lumen, which is to the lavage or non-dependent side, and the dependent lumen is connected to the ventilator. Both these tubings are firmly secured to the pillow. Now, doing physiology, when you initiate one lung ventilation, the non-ventilated lung will be deflated, right? So this perfusion will create a shunt, okay? It will not take up any oxygen here because there is no ventilation here. So what happens here? That shunt fraction will increase. In the inflow phase of lung lavage, this cavity is further filled with the fluid. The blood or the perfusion here is diverted to the opposite lung. So you have more amount of blood which is available in the ventilated lung to pick up oxygen. So you have decrease in the shunt fraction and momentary increase in the saturation of oxygen. Okay. Now in the drainage phase, opposite thing happens. This cavity will be drained out of the fluid. The blood will be diverted back to this lung, and then your shunt fraction will again increase, and again you will have a momentary decrease in the saturation. So this thing is only for academic interest, that there is increase in saturation during inflow phase and decrease in saturation during drainage phase. This does not have any relevance in the overall management of our case. Now, seal pressure is very important. I'll explain it in this cartoon here. When you have placed a double lumen tube in the thorax, okay, and you have filled it with water, certain factors like increase in height of the reservoir fluid, higher inflow rate of the inflow fluid, higher filling volumes, more than 500 ml, and the loss of lung isolation will cause water to move around this endobronchial cuff into the opposite lung, or move around the tracheal cuff out into the lung. That means the seal pressure which was offered by the bronchial cuff and the tracheal cuff is now broken. Okay. So how do we define seal pressure? It is the intraluminal pressure of endotracheal tube, in this case double lumen tube, that prevents the retrograde or leakage of air or water around the cuff to the opposite lumen, right? So we tend to keep a seal pressure, or to achieve a seal pressure of around 30 to 40 centimeters of water, right? Now, what happens if the seal pressure is broken? The water will come out to the opposite lung, right? And you will have a soiling of opposite lung. So you will not be able to ventilate this patient. So this is a worst case scenario. So before proceeding with the lung lavage itself, you want to find the seal pressure. That means you want to mimic the worst case scenario. So when you are mimicking the worst case scenario, you're not using water for that. You're just using air for that. Okay. So in that, what you do, you make the patient apneic. You connect one lumen, this lumen, to the ventilator, and you clamp the other lumen. To this lumen, you keep on gradually, sequentially increase the pressure using the APL valve from 10 to 20 to 30. Initially, there will be no backward leak. The air will flow from here to both the lungs, right? But there will be no backward leak, right? The point at which this backward leak starts occurring, right? So you can connect two things here. You can either attach a capnometer or you can attach a underwater seal. So the point at which you see the capnometry trace here or the bubbles in the underwater seal, that point is your seal pressure. Okay. So this is the video showing the seal pressure measurement using capnometry method, right? So what we have done here is you are clamping one lumen. To the same lumen, you have attached a side stream EtCO2 tubing. Here you see that the EtCO2 trace has now stopped. Okay, that means the seal has been achieved. Okay. Now, other method is the underwater seal method. In this method, you are attaching an underwater tubing with underwater seal. You are clamping one side and you check for appearance or disappearance of bubbles. Now here you will see that bubbles are still coming. Okay, that means the seal has broken or it has not yet been achieved. Okay, so these are two methods of attaining the or knowing the seal pressure of double lumen tube. Now the first phase is the inflow phase. Now the receding level or in the reservoir bag will tell you that the fluid is moving into the lavage lumen. So here you can see that the movement of fluid in the non-dependent limb. Okay, you will just see here, right? So this is the fluid going into the non-dependent lung. Okay, once you have filled it with 500 ml, your inflow phase gets over. Next comes the chest percussion physiotherapy. Now you have to, performing chest percussion physiotherapy, you have to make the patient in head low, head high position, right tilt and left tilt, so as to make sure that the fluid gets equally dispersed in all the zones of lung, and you have better displacement of the surfactant material. Okay, and this is carried for a period of around 5 minutes. Now, in the drainage phase, you unclamp the lumen and you see this curdy white fluid coming out through the lavage lumen. Okay, this is the drainage phase. I've intentionally kept the voice on for this video, right? Because you are seeing that even while you are performing the inflow phase or outflow phase, the chest percussionist is doing his job, right? So chest percussion physiotherapy is to be performed throughout the procedure. Okay. Now what happens if the soiling of opposite lumen occurs? That means that there has been water spillage to the opposite lung. Here, if you see it in the video carefully, you can see the water in the opposite lumen. Okay. So you will get to see that there's outflow of saline from the ventilated lumen. This was a ventilated lumen or double lumen tube. There will be appearance of bubbles in the outflow fluid. There will be a reduction in the tidal volume. There will be increase in the airway pressure and patient will desaturate. Okay. So what happens when you have lung soiling? Don't shy away for calling for help, right? Discontinue the lavage inflow fluid, ventilate 100% oxygen, remove all the fluid passively or actively from the lung, resume two-lung ventilation, check for lung isolation and placement of the bronchial cuffs by using fiber optic bronchoscopy, recheck the seal pressures by capnometry underwater seal, and in the end of it, take a decision whether to abandon the procedure or continue the lavage procedure. Now here you see in the initial, now this is one cycle of lavage. That means one inflow, one percussion and one outflow, right? You sediment which has deposited, settled in this bottle. In the second bottle, sediment is more, and this is the last bottle. So we have completed nearly 14 cycles of lavage. Okay, here there's hardly any sediments left. So this is how you decide when to continue or discontinue the lavage procedure. Now, when to call it a day? When you see the gradual clearing of drainage fluid, see all this fluid is murky with some amount of sediments, and the last few cycles are absolutely clean. If you have repeated soiling of the opposite lung and there is failure to maintain oxygenation, or patient has become hemodynamically unstable. And post-procedure, you remove the double lumen tube, replace it with single lumen endotracheal tube. You give some diuretic. If there is discrepancy between the inflow and the outflow fluid, patient will need to be electively ventilated overnight. with serial ABG monitoring, and post-procedure, post-extubation, he will require some sort of a non-invasive ventilator support. This was a pre-lavage patient where patient could hardly lie down supine. He was propped up. He was on BiPAP and 100% oxygen, very high flows. He was maintaining saturation of around in lower 70s with PO2 of 32. And this is his post-extubation. The next day, he is comfortably sitting up with nasal prongs and saturation of 93. Now, to conclude, the main idea of this procedure is to get improvement or to achieve improvement in oxygenation and improvement in quality of life. These patients are chronically hypoxemic and hypercarbia. So it all involves the airway exchange across alveolar capillary membranes. And we have to take all the measures in which you can prevent the lung soiling. These are the points of discussion which can be discussed if the time permits. I end my topic here. Thank you.
So thank you, Dr. Chetan. This is all from our team. Over to Balkrishnan, sir.
Sir, do you have any questions lying in your box? If not, you can invite questions.
No,
I can't.
I think this is, yeah. So about the role of positioning in during HiPec, whether you rotate the patient or what you do, like head low and head up. Yes, we do that. And that is definitely necessary for the uniform distribution of the perfusate. So
Yeah.
Trendelenburg, anti-Trendelenburg, right tilt, left tilt, all the positioning is done while the HiPec phase is going on.
Dr. Chetan? Dr. Chetan, I have a question regarding your presentation.
Go ahead with the question.
Dr. Chetan,
Go
can you
ahead with the
can you hear
question.
us now?
Yes, I can hear you.
Yes, I have a little question regarding your presentation. I wanted to know that why do we prefer the upper lung for lavage and not the lower one?
Actually, both have been described. Even the supine position or prone position, all have been defined for performing the lung lavage. It is said that the physiological, which I have explained you earlier, when you perform in the when you lavage the non-dependent side, the amount of blood which is shunted to the opposite lung for uptake of oxygen is higher. Okay, which doesn't happen in the when you do a dependent lung lavage, right? That is the only reason why it is preferred. That is a reasoning which has been given for that.
Because I believe that with gravity, there'll be less spillage if we're using the lower side. No.
That is, the reasoning is perfectly fine. But even if you perform the lower lung, even if you lavage the lower lung, you have to find the seal pressure, right? There are factors which cause a breakage in seal pressure. If you're able to take care of those factors, even the non-dependent lung lavage is quite safe. And over a period of uh, these 6 cases, my particular incidence of soiling was nearly 3 to 4 times in the first case, which has decreased to nearly 0 as of now in the last case.
Nice. Thank you. Dr. Chetan, there is a question regarding your presentation in the chat box. It says, what are the major problems you faced during the lavage? How do you monitor and maintain temperature?
Okay, first I'll take the second question regarding temperature. Yes, there is a lot of because there is a nearly 500 ml of fluid is infused and taken out in one cycle, right? So there is a loss of temperature here. The fluid that we use is near the body temperature, so we do not use cold fluid. We do not have very warm fluid. Patient is covered with a warming blanket, and all its extremities are covered, right? We used a forced air warming device also. In spite of that, they are in the lower range of normothermia. Not they don't remain normothermic. So it depends upon how many cycles you have done, right? So if like when we began to do this, we used to do around 30 to 35 cycles for one patient, right? Now we have come down to can I know second question?
Yeah,
Anupam?
second question is, Dr. Chetan, will crystalloid be sufficient for IV replacement during lavage, or should we replace with colloid? Do we need to transfuse?
See, we are not we are just giving around 1 to 2 ml per kg per hour. That's enough. Crystalloid is enough. See, we have used invasive cardiac output monitoring because it was available to us free, right? So we found that intraparenchymal absorption of this fluid is minimal, right? And so you just need to replace the maintenance fluid that is around 1 to 2 ml per kg per hour. We use plain ringer lactate because it is biological. It is it it's normal electrolyte solution. Yeah, we don't use any colloid. There's no volume loss here. In fact, we need to give some diuretic because, see, if suppose you have infused 500 ml of fluid and in the drainage you get 450 ml of fluid. So you keep a chart of it. So over a period of say 20 cycles, you are positive on a positive side of say 1 liter or 1.5 liters. So you need to give diuretic in that case. Yeah, that's it.
Yeah, and there's one more question. Lung lavage, is it done bilaterally?
Yes, it is. That's why I started my topic of discussion is sequential lung lavage. Yeah, it is done one after another. So you, in case patient has left side which is more affected, so you do the left side first. If both the sides are affected more equally, right, again you do the left lung first because it is a smaller lung. You have a right lung which is available for you in case something happens wrong, right? So smaller lung first in case it is bilaterally symmetrical, or left lung first, or whichever lung is more affected that is done first. And the patient is given a rest for next 3 to 4 days and taken up again after maybe 4 days or a week, depending upon many other factors. We do this. So patient requires a hospitalization of roughly around 2 weeks. According to the literature, which it says that the second lung lavage should be done at least 2 weeks after the first lung lavage. I think, but in the corporate setup, the whole cost of the procedure is too much that we can't wait for 2 weeks. Mostly these patients are they are from out of Delhi. Some are from out of India also. So once we feel that his oxygenation parameters have improved, we take him up for second lung after 3 to 4 days. People have performed bilateral lung lavage in the same sitting, but we have not done that.
And for how long remission is there after lung lavage?
Yes. There are probably there are two types of pulmonary alveolar proteinosis. One is the primary, this is idiopathic, other is the secondary, which is occupational exposure. In the primary ones, it has better prognosis. They're also given granulocyte, immunomodulators before our procedure, right? But those immunomodulators are very, very expensive. They decrease the patient's immunity also. So one of our patient who was from primary or idiopathic type, he was not given immunological treatment. He directly came for alveolar lavage. In our whole set experience of past 6 months, the past 6 years, the first one was in 2018. We have performed lung lavage the second time for one patient after 2.5 years. So because they follow up mainly with the respiratory physicians, not with us, so we really have no idea when are they coming back to the physicians for follow-ups. But practical point of view, I have seen we have repeated a lung lavage for one patient after 2.5 years. In the secondary variety, if it is when it's because of the occupational exposure, they are advised to change their occupation. Otherwise, the incidence of or the chances of remission is the recurrence is theoretically high. Theoretically high.
Thank you, sir. I think we are done with all the questions, Dr. Anil, sir.
I feel,
Request. Yeah.
yeah,
Please,
it's
carry on,
open
sir.
to you. Over to you, Dr. Ajay. Yeah.
Yes, sir. Thank you, sir. Now I would request Dr. Radhakrishnan, sir, to give a vote of thanks and conclude the session.
Thank you, sir. If there are no further questions, I think we can wind up the session. This is a different webinar. Not many people talked in the past on these areas, especially on the bronchopulmonary lavage. And well, I'm hearing for the first time sequential lavage. I have seen, but I was not told about the sequential lavage. And the topics were excellent. And I remember what our friend was suggesting, that he may be interested to come out with newer areas. Well, if these sort of topics are made available, Anupam Sharma was telling that these new areas in which we are laying hands to be tried out again and again. I will keep up that particular word of Anil
Thank you.
and will invite later for further topics of similar nature.
Sure, sir.
Yeah.
And all the best for your conference tomorrow, sir. And surely I assure that definitely my team will be participating in the next conference.
Yeah.
Definitely when it comes.
Yeah. Thank you, Anil. It was a wonderful
Thank you, ma'am.
webinar.
Thank you so much.
Jayashree,
Thank
please.
you. Just thank you so much, and
Thank you.
hope to see you all next sometime soon.
Sure, ma'am.
Thanks.
Any day, ma'am. Thank you, ma'am.
Thank you, ma'am.
Thank you, sir. Thank you, ma'am. Thank you.
Thank you, dear. Bye.
Bye, ma'am.
Thanks, Chetan.
Bye, ma'am.
Bye.
Thank you so much, everyone. Thank you so much.
Thank you,
Hope to
Shreya
have
ji.
you
Thank very
again.
much.
Thank
Yeah,
you so much.
Thank you,
Take
Dr.
care.
Ajay. Thank you very much. Thank you.
Thank you. Thank you. And
Thanks, Ajay.
you all
Thanks,
were
Ajay.
saying,
Thank
and
you.
thank you.
Thank you, Ajay.